9th May 2020, the Straits Times featured an article, Mental Health Fallout. COVID-19 and its associated circuit breaker measures have exacted a toll on the mental health of people in Singapore and has impacted various groups. The National Care Hotline set up to offer extra support, and it received more than 6,600 calls in less than a month after it was first launched on April the 10th. It is important then for all of us to learn how to cope with the stresses of life and keep depression away. We are glad that we have a panel of speakers who will be offering us this good news of hope in depression prevention. Today, we have with us the finest of the finest speakers, all distinguished speakers who will be sharing from different angles and providing us the hope against depression. Please allow me to invite Professor Heok, the Tan Giok In Professor in Psychiatry and Neuroscience from the Department of Psychological Medicine, NUH, to tell us more about the Lee Kim Ta lecture and also to introduce our keynote speaker, Dr. William Wan. And Dr. William Wan is also known as Mr. Kindness. Prof, please.
Thank you, David. I'm delighted to be in this webinar. I know that there are people who have signed in as far as Australia and also from KL in Malaysia. And Mr. David Lim is speaking from a place in Jurong Point shopping mall called TARA. TARA stands for Training and Research Academy at Jurong Point. And this place is the first research center in Asia that is anchored in a shopping mall. You would have thought that research centers would be in a university or in a hospital or clinic, but it's the first time in Asia it is anchored in a shopping mall, and it's a unique idea. It has stirred up the imagination of many people in other parts of the world that it's possible to do something different. And this is for prevention. And I'm very glad and for the generosity of the Lee Kim Ta family, especially Mr. Lee Sun Tek. I hope he can listen in today. And they've been helping us for more than 6 years in setting up this center. Now, the 6th Lee Kim Ta lecture was delivered by Dr. William Wan. Yeah, I'm sure he needs no introduction. He'd be most unkind if you don't know him. He is not only a lawyer, but PhD, and also a pastor. But he's also, people would have thought that he's somebody whose life will be smooth sailing. I've spoken to him a couple of times and read his story. He's gone through difficult moments of his life. Gone through a tempest, to high wind, rain, storms, but he survived. He's a tremendous, resilient person, and he recently told me that he was not feeling well, and told me that he was in Tan Tock Seng Hospital. But there's also always a sense of optimism when he sent me his email on his WhatsApp. He did not say that I'm hospitalized. He said I'm in Tan Tock Seng for a staycation. And there's a level of optimism that is very important in our life. That when the chips are down, you can still have a sense of humor. Some of you have read his book called Living and Leaving Well. Instead of saying living and dying well, he says living well. This is a wonderful person with nuggets of humor and wisdom. And in his book, he quoted many people, Shakespeare, Wordsworth, Robert Browning. But I hope Singaporeans will begin to realize that there are lots of wonderful people, scholarly people that we should be quoting him, quoting the wisdom of William Wan. rather than keep on quoting Shakespeare and Wordsworth. Now, I enjoy listening to the Sunday radio program by Brian Richmond, 90.5, on old time music, and William has been a guest, and he insisted that the DJ Brian Richmond should end up with something about kindness, and indeed he has done it. And so the last few weeks end up with being kind to your neighbors, kind to people, and so we are waiting for Mr. William Wan to tell us about his difficult times and how he survived, and so much we can learn from you. Dr. William Wan, please, our General Secretary of the Kindness Movement in Singapore.
Thank you, Prof. Thank you all for joining us. Thank you for having me. I welcome opportunities to share and hopefully to encourage people as we go along our way. Yes, I want to talk in this lecture very simply about how I personally, as an individual, cope with stress and prevent depression. By preventing depression, I mean clinical depression. I'm sure I must have been depressed sometime along the way. Like many of us must have experienced that kind of depression. It's not chronic. It comes and it came and it went. But the symptoms, of course, were there. But thankfully, it didn't become chronic, and so that I didn't have to take a medication or to see a psychiatrist. Somehow, by the grace of God, I would say, managed to overcome that. So I want to share a little bit of that. So if you go on to the next slide, I just want to tell you about my life in chapters. I think many people who have known me would say that I live a very stressful life. I am a very curious person. I'm a lifelong learner, and I keep adding knowledge to my life, and and so you can see that I am almost everything. And some of these are very interesting. They were done, at the same time. For example, while I was an ordained minister, I was already taking up some courses and learning about psychometrics and about different things, about philosophy, and taking graduate degrees and all that. In fact, when I was a lawyer, I was also an honorary pastor of a church. And so, these kind of life, and then living in altogether about 6-7 different cities, working in different cities in North America and Southeast Asia, moving the family, raising 3 children. Everybody says your life must be very stressful. Well, let's see what stress is. If we look at the next slide, I think that it was stressful. But I think of stress in terms of a rubber band. I think stress is good. In fact, I think I work best under stress. When I have a deadline, writing for the Straits Times, especially when there's a deadline, I perform better. Taking exams, when there is, closer to exams, I seem to be able to remember better. So I'm just maybe wired that way. But stress, yes, it's like a rubber band. The rubber band is very useful because of its elasticity, its ability to stretch. And when you stretch the rubber band, I'm sure you're stretching it. But if you overstretched it, that rubber band will go burst. And so it won't be very useful. I think my life has been stressful. Sometimes I take appointments and do speaking engagement back to back, and then preparing for talks can be very stressful. And I am aware of that. But I'm also conscious not to stress myself so much that I will break. So I take time to listen to music, I take time to reflect, and so on. And I'll share with you more about that. So yes, it's been stressful. If you go on to the next slide, you'll see that I burn my candle at both ends. Why do I say that? When I was 60 years old, I had a little celebration for my 60th birthday with some of my friends. And my MC did some calculation and surprised everybody and said that I wasn't celebrating my 60th birthday. I was celebrating my 90th, because he added the years I worked, added the years I went to graduate school, the years I did this and I did that, many of that concurrently. And he said that I must be 90 years old. Well, it did shock me because I never look at it that way. But if you do some calculation, yeah, it looked like I actually burned my candle both ends. Up to today, I am very happy to be able to share with you that I am still functioning well, though as Dr. Professor Kwa said, I am being investigated for some inflammation. They're trying to find out what the real cause is. Meanwhile, I am functioning normally. I'm looking forward to know the answer so that it can be treated, so that I can move on. But I seldom get sick. And so it was quite surprising to many of my friends that I landed up in hospital quite recently for 5 days. But all of that was for investigation. They probed me, they pricked me, they poked me, they did everything to me to find out what ails me. Well, it may be the result of my burning my candles both end, and I'm at 73 paying the price. But if that was so, I'm quite happy to accept that as a consequence, because I believe in living a full life. That's why I wrote the book about living well and leaving well, a full and positive life. As long as I can live and I can breathe, I want to be proactive. I want to contribute. I want to be positive. So that's what I think. Next slide, please. So depression. Recently, I not curated. It was curated by somebody else, but I moderated a conversation between three of my friends who are recovering from depression. In fact, a couple of them did entertain thoughts of suicide. One of them was a parent of a son who committed suicide because of depression. And they were saying that I said depression is like going into a very dark forest, very dark, and the sun doesn't penetrate into that forest, and you have all kinds of creatures in that forest, and they are very frightening. And the father of the son who committed suicide said that actually it's more than a forest, it's a deep forest in a deep valley. Now I must say that I've experienced burnout once. I've experienced depression, but not chronic, not what psychiatrists would label as clinical. But I experienced listlessness, losing interest in some stuff, but it didn't last very long. Somehow I managed to get out of it, and I will tell you how that happened. The next slide is about episode number 1. The kind of stuff, the storm, the earthquake that Prof. Kwa was talking about that I experienced. This is not a picture of my daughter, but my daughter looked worse than that when she was 14 years old. Out of the blue, while I was happily doing my work as a consultant in Washington, D.C., as a senior minister of a large church in downtown, as a respected community leader in Washington, D.C., in the Chinese community, my daughter at 14 decided to drop out of school. She became a punk. She left home at 16, told us, "Mom and Dad, it's got nothing to do with you. I love you, but it's time for me to leave because I'm making both of you very unhappy, and I know it's not right. So I need to find my own way." So we let her go. The mother, my wife, was almost in depression. Every morning, she would have gone to the room and cried a river. It was a very difficult time. But I had to continue my work. I had to continue all the commitments that I had. And I have to live. And life has to go on. And then we came back to Singapore soon after that. And she called and said that she's pregnant. And she wanted me to go marry them. I had to make a difficult decision, because if I had gone and given her the impression that I support and endorse her lifestyle, that wouldn't be right. But if I didn't go, I could have lost her, because all along for all those years, we kept our doors open. We were still in touch by phone, by email, by text. And then our grandson was born when she was 20 years old. We went and supported her at that point in time. At 22, she divorced. And then she called and said, "Dad, I want to make you very happy." I said, "How?" And she said, I realized that I made a big mistake in my life. I should have listened to you. I'm going back to school. And so she returned to school with a son in tow. And at 31, she graduated with a PhD. She's now 40 years old. She taught at the university briefly, and now she's a professional potter. She has a studio. She's a very happy woman. Her son is she's now 44. Sorry, not 40. Our grandson is now 24 and a doctoral student in robotic engineering at the same university. Now you ask, how could I survive that? I was a community leader, a preacher, a pastor, and here my very own daughter went exactly against everything that I believe in, everything I taught. How did I survive that? Next slide. Episode number 2. I was 51. I came back to Singapore. I became a leader of an organization that I helped. I contributed significantly to the founding of it, a non-profit organization. They wanted me back very badly. We were very happy in the States. We came back because I have a sense of wanting to respond to this very long request for us to come back and lead this organization. I've led it before. This was the second time. But somehow, over the years, we were away for 25 years, things changed. The whole constitution of this organization changed. People changed. I only lasted 2.5 years and I was fired. They gave me 24 hours notice to pack and leave the office. I don't want to go into all the details, but it's very painful because, it was my life. I came back for it. And I was 51. I still have the daughter who was still in rebellion. I have a son who's still in school. And I was fired. I left a very good position in America to come back, and I was fired. I had to go back to practice law. I went to talk to my friends in law practice, and they said, we know who you are, you're great, and you can do it, but you've been away so long. We're not sure how you're going to do it. If we give you a junior position, it's not fair to you. If we give you a senior position, we're not sure if you can do it. So I told them, don't pay me. Just give me an office and support. I will eat what I kill. And within 8 months, they made me a senior partner. And by age 64, that organization that fired me called a meeting to apologize to me. Took them 14 years. How did I survive all that? Okay, next slide will tell you how. Well, this is me, and I hope some of you can resonate with that. I have the 3 F's. In the next 10 minutes, I'll share with you the 3 F's. The first is faith. I am so thankful that I choose to believe. I choose to believe in God. I don't argue about God. I just choose to believe that there is a God. And in my case, I chose a Christian version of the God, and I believe in him. I gave myself to serve him in the churches, serve him in charity, serve him as a lawyer, serve him in anything that I did. In my writing and my speaking, I honor God. And this faith in God gave me that dimension, where in the moments when my daughter decided to rebel and there was nothing we could do about it, we were confronted with a situation where, believe me, we were totally helpless. No intelligence, no counseling expertise that I myself have as a counselor, no theology, no philosophy, nothing could help me. I had to get down on my knees and believe in God and ask God to help me. And ask God to save me from getting depressed. I actually talked to God about these things. I don't know. Some of you may have faith, may not have faith. It's okay. You got to make your own decision. But that's how faith helped me. I believe in God so much that I really believe that he's real. And I talk to him maybe, and he responds to me. Mysterious ways. Mysterious ways. I say, God, I want to keep in touch with my daughter. I don't want to lose her. Help me to be able to talk to her in such a way that I will not cut our relationship forever. And that sustain our relationship too. It's a difficult relationship. Very difficult. If I say the wrong thing, she would just turn and be gone. And that lasted 7 years before she turned around. Today, she is the most affectionate of all our children. She's the one who called almost every other day, all the way from Canada. Faith sustained that relationship. Faith caused me to be positive, optimistic, believing that the worst will end. There is light at the end of the tunnel. How long, I do not know, but I have a responsibility to stay on course and not get depressed so that I can't even help myself. You may call it strong will, you may call it whatever it is, but I attribute that to the presence of God and his help in my life. Second, the fighting spirit. What do I mean by the fighting spirit? The second episode, they told me that if I wanted to, I could go back to the United States and they will pay my air ticket and everything else so that I can go back. In fact, before the firing, they were trying to get me to do something which I felt it wasn't right. But if I had done that, there would have been no problem for me. But I have a great sense of right and wrong. And I fought it. And to cut the long story short, the leadership, the board, felt that I had to go because I was making it difficult for them and for the organization because it was splitting the organization. And so they band together and give me that pink slip. You see, there are easy causes under those circumstances. Make life easy for everybody. But that's not me. I knew it was wrong. And I knew that if I left Singapore at that time, it would just confirm that whatever they said of me was right. But I can't do that because it was wrong. But then some will say, oh, who cares? You go back and you forget about Singapore. Nobody would remember after a while. Let them say whatever they want. I say, I cannot do that. I have to stay in Singapore and watch this come to a conclusion. And I kept praying about it. And I refused to roll over and die. And I refuse to concede that they were right. So I have a fighting spirit. I believe in justice. I believe in right and wrong. And I believe that you just have to have that resilience and that fighting spirit. And again, I refuse to go into depression. I don't know what my psychiatrist friend will say when I kept saying that. I'm sure, pardon me, I'm sure that's many of you who are also recovering, maybe saying, look, there's no way you can fight it. It just come upon you. Yes, I have known that. Even as a pastor, I have gone to visit members who have been depressed. You couldn't even get out of bed, couldn't even do anything. I understand that. But in my case, somehow I didn't get to that state. Because I kept telling myself I must be useful. I got a battle to fight. I got to win this battle along the way. I cannot afford to die. So maybe the third is the key. One of the important keys, fearless sharing. I wasn't averse to talk about it. Anybody who wants me to talk about it, I talk about it. I talk about my daughter. I talk about my firing. I came to the point where I wasn't ashamed of it. And as I talk, and then I wrote, and as I wrote, it really helped. I wasn't bottling them inside me. And I have good friends who are prepared to listen without judgment. And it helped a lot. In this regard, I want to recommend that you go to check out this Tapestry project. I started by Tapestry Project SG. Tapestry, I think is TAPESTRY. Started by this young friend of mine, Nicole, who went to depression very early, about in her 20s, early 20s. And through journaling, through writing about her experience, she was able to come out of it with the help of psychiatrists. And now she started the project to help people to journal out of depression. Go and check that out. It's a good project. You can learn from her. So these are the 3 F's that got me out of depression. And next slide, please. So I wrote a book, this last book, the 10th book, about living well and leaving well. Because in it, I share my understanding of what it means to live well, to live positively, to live enthusiastically. In spite of episode 1 and 2, I kept on living enthusiastically, refusing to give up living. I talk about how we can live to make a difference to people's life, to live purposefully and meaningfully in spite of our own troubles. I talk about kindness in this book. And the second half of the book is about how we should live well in order to leave well. And leaving well, there are things we need to do too, so that we don't leave a mess behind after we are gone. And that's very important, because we want to leave something well, even as we live well. So I would like to recommend my book. Next slide. I have it's out of stock now, so I have a small stock with me. If you're interested, it's $32 and P&H. You can next slide is a picture of my my contact. You can take a shot of it. Just text me or email me, and I'll be happy to mail it to you. I believe that this book will help you, because I strongly believe that having a positive way of life, having a enthusiastical spirit, and having a fighting spirit, a sharing spirit, and if you can find faith, that would be good. It will help. So please support this poor writer if you can. Thank you very much. That's all I have time for. And yeah, may I say God bless you. I really believe in that. Thank you.
Thank you, Dr. William Wan, for sharing such personal struggles. Your fearless sharing gives us hope. Indeed, tough times never last. Only tough people like you can persevere and conquer life challenges. I believe some of you have some questions to ask. Please use the Q&A function for questions, and we'll discuss those questions after the fourth speakers has spoken. And you can even upvote questions that align to what you want to ask. And so if that particular question has more click, you will actually surface to the top. So for those who want to upvote those questions, please do so. Let me now introduce the next speaker, Dr. Chee. Dr. Chee is a consultant child psychiatrist and also for adolescents in NUH, trained in England at the Institute of Psychiatry, London, and Tavistock Clinic. He has research interests on suicidal behaviors of youth and Chinese brush painting as well for mental well-being of seniors. And today, he'll be speaking on the topic, the depressed child. What can parents do? Dr. Chee, please.
Hi, good afternoon, everybody. I am Zijian. I'm one of the child and adolescent psychiatrists currently working at NUH. So today, I am very honored to be given this opportunity to share with everybody what we can do to help our children or our grandchildren or just little children of our friends or anybody that we see who might be going through a difficult time, who might be depressed or just low in mood. Okay, and I think now more than any time in recent history is more relevant than ever to discuss the depressed child. So the clue in this slide is the mask that this little young man is wearing. It's COVID pandemic season, and just in 2020 alone, the number of referrals that we get to NUH for the depressed young person, for the suicidal young person, for the young person that is not coping well, is more than ever before. My waiting time has doubled. I'm also looking after young people in the ward, and the ward numbers have also doubled. So it's a very difficult time. And when a young person is feeling depressed and not coping well, what that generally means as well is that the family is having a big difficulties. For children are always the barometer of the mood in the family. So childhood depression is real and why it matters. So for a lot of people from my generation, from my parents' generation, they don't really recognize that children can get depressed. And to a certain extent, it's true. Most children are very resilient, very adaptable. Most children, they get moody, they get grumpy, but they don't really get depressed. And clinical depression, a bit like what Dr. Wan had said earlier, is persistent. It's not something that takes place momentarily and you get over. It is persistent. It stays for a long time. It invades into every aspect of your life. Unfortunately, depression rates among children are going up. Worldwide numbers, 7%, so 7 out of 100 young people are very depressed, and 3 of the children who are technically below 12 years old gets depression. And that is a number that's probably quite similar to Singapore numbers as well. Okay, and worryingly, more and more young people at younger ages are getting depressed or clinically depressed. COVID-19 numbers, we are not sure yet, but I won't be surprised at all if the numbers get worse. So a good question, let's try to identify a depressed young child, shall we? Everybody, if you look at this young girl on the screen, is she depressed? It's really hard to tell. And I'm a child psychiatrist, I can't tell. Because this is a cross-sectional picture. You can grayscale the picture, you can color the picture, you can't tell. you have to, but there are certain clues, okay? So not every child is the same, and a child that do not show sadness or depression, they don't show it like adults. Adults, we learn how to show that we are depressed. We learn how to behave when we are depressed. So people around my same age group, we have learned that if we are feeling sad, you know, we will go home, we will look very sad, we might cry, we might drink alcohol to excess, we might, shout and ventilate our feelings at our spouse, we might kick the cat when we get home. But depression in children are very different. They haven't learned what is the socially acceptable way of being depressed. Okay, it is a learned skill. Okay, and therefore a lot of times we don't really understand and we don't really diagnose them accurately enough. So what to look out for? These are not 100%. Oh, if your child has this, he or she definitely has depression. But it points towards maybe I should bring to a child psychiatrist to be seen, I should bring to a doctor to be seen. Is your kid more irritable, angry, sensitive to criticism? Is he or she crying a lot more? Or do you find that your child is withdrawing, isolating, staying at home, not wanting to do anything at all? In the past, he or she might want to go cycling, meet up with friends, but not anymore. And COVID-19 pandemic has really exaggerated and worsened a lot of these symptoms. Your child can have abnormal appetite, and what I mean by that is sometimes they eat a lot less, but sometimes if they're depressed, don't be surprised if they eat more, they sleep more, or they sleep less, they cry a lot more, and they couldn't concentrate in school. But of course, the big warning signs are the 3 S's. Are there substance misuse? If your child is drinking too much alcohol, is he or she self-harming? Or is there constant thought about wanting to end the life? When children think about ending their life, it usually means something more serious. Of course, it could be trying to escape, a fantasy's escape kind of way, but it is serious enough. And if that happens, we should think about getting help. And just a quick run through about why do children get depression? Most of the time, we might not know, but there are usually some clues. Is there a significant life stressor? So has there been family separation, COVID-19? Has there been a loss of jobs in the family, financial hardship? Sometimes it is genetics, unfortunately. We all get different gifts, strengths, weaknesses as per our genetic set. If there is a family history of depression, anxiety, then look out for your child or your friend's child. Is there problems in relationship? So are the parents fighting with each other? Is the relationship with the parent or the brother or very close friend in jeopardy? Is there academic stress in school? Is there school bullying? These are all relevant. Or are there other mental health problems? So evidence is very clear nowadays that shows if there is other childhood mental illnesses or physical health illnesses, ADHD, autism, other chronic ill health, rheumatism, even cancer in young children, these can all predispose a young child to feeling more depressed or being at risk of getting depression. Okay, so if you suspect your child is depressed, seek consultation, don't delay. There are the child psychiatrists like me that can help. There's the pediatrician who can see even younger children. And don't worry about stigma. It's not really a thing nowadays. Confidentiality is something that all doctors will keep for you and your family. And also something that I get a little bit worried when parents or caregivers bring their children to my clinic is, oh, doctor, is my child telling the truth? Is she trying to manipulate us? Usually, especially the younger they are, it's less likely to be the case. It's just that they did not know how to express how they feel, and therefore they couldn't communicate as well. So don't worry about that part. Okay, so treatment does not always involve medication and therapy if we start early. Okay, so most of the young people that I see for the first time, I don't prescribe them with medications. In fact, I also don't, we will discuss with the family if they need therapy, all and well. But sometimes all it takes is some lifestyle changes and some changes to their parenting. And there can be massive, massive changes to their mood and, if I may say, even help with the depression. Okay. So I would like to give 5 general evidence-based tips for how to raise healthy, happy children. I think the narrative has to shift. I think we shouldn't be waiting for our children to become depressed and then we treat. What we should do is we should try to prevent, we should try and focus on the positive. So what are these 5 tips? Tip number 1, sleep is really important. So it rejuvenates the mind, it helps your child grow physically. Regular bedtime also builds in a routine, which is very settling for the children. And good bedtime also has an indirect effect of improving the mental health, prepare them for the stresses of the day. And the stresses of the day for the modern Singapore child is very high. School is very stressful. Relationships in school can be very stressful. Social media, potential for being cyberbullied is very stressful. The more we can prepare them, the more sleep we can give them, the better they can cope. Food, also very important. Breakfast is really the most important meal for children, much more so than for adults or elderly. Breakfast is really key. Also, again, sets up a predictable morning routine. And relationships. So relationship is really important. In our modern Singapore family, we tend to have nuclear families. So the parents, they get a BTO, they move into the BTO, they have 1 child, 2 child, and that's it. But the old saying goes, it takes a village to raise a child. And you want to have, you want to be close to your grandparents, you want to be close to your siblings, the cousins, the neighbors, because what this does is it brings about a sense of connectedness, relationships, and this gives meaning to the child's daily living, and it improves mood. And of course, it also gives a place to provide support when necessary. Recreational time, it is more and more important, especially in today's time, because with the right recreational time, they learn to overcome obstacles, deal with life stresses. Learning new skills gives them a sense of self-confidence. Overcoming obstacles in play helps them and shows them, perhaps build a bit of resilience that they will not give up when things are hard. The opposite to not providing the right recreational time or the right downtime is if you don't support, then what that means is that then they will decide how to make use of their spare time. And oftentimes you see young people using their mobile phones, the iPad. Not that they're not good devices, but they should be supervised. Okay. And positive parenting. Our children can be going through difficulties, unable to express themselves, and they need guidance. They need gentle guidance. They need mutual respect. They need parents to treat them with a certain level of respect, to show them that there can be setbacks in life, and setbacks are but a learning opportunity. And be consistent, be patient, and follow through. And the message gets passed to your child a lot easier. Okay. So in summary, I just want to say that instead of thinking about how to identify and treat your depressed child, let's start by learning how to parent healthy and happy children. Okay, so a positive lifestyle habit that starts with yourself, that you can pass on to your children and grow together and learn to reflect on your parenting together is very helpful for the whole family. And of course, always learn the skills, learn the knowledge, what to look out for if your child is depressed. And if you think they are, maybe they are not, then of course seek help and don't delay. Thank you very much.
Thank you, Dr. Chee. I believe many parents have found your talk helpful, and even grandparents. We are glad to know that there are preventive strategies. Now, for some of you who have questions, please use the Q&A function. Just type in your question, and we'll discuss later after the final speaker has spoken. And you can even upvote those questions. Let me now introduce you the third speaker, Professor Rathi Mahendran. She's a senior consultant psychiatrist from NUS, former chairperson of the medical board of IMH. She has conducted the first study in Asia on dementia and depression prevention at Jurong. She's also the lead researcher of the community health and intergenerational study in one of PCES centers in Toi Drive. And she'll be speaking on the topic, the depressed elderly, early signs and treatment. May I pass the time to Prof. Rathi to share with us.
Okay, so thank you, Mr. Lim, for that introduction. And good afternoon, everyone. Glad to have you with us on this lovely Saturday afternoon. My talk is on the depressed elderly, early signs and treatment. And some of the things that Dr. Chee talked about in the child, issues about depression in children, I think will also be applicable in what I'm going to say in the next few slides. So can I have the next slide, please? All right. So depressive disorders are the most common mental health problems among the growing older population today. But depression is not a normal part of aging. And this is something we must remember, because if we ignore the sadness or the low mood that occurs in the elderly, then we will find that we deprive the older individual of life satisfaction and a good quality of life. Now, most older adults actually feel satisfied with their lives, despite having multiple medical conditions, physical problems. But it is the life changes that occur with aging that sometimes may cause distress and sadness. Next slide, please. So what are some of these life events? And there are several of them. I've just highlighted probably some of the most significant ones that can affect an individual. And on top of that list is, of course, death of a loved one. It could be a spouse, a family member, a close friend. Moving into retirement often is a huge challenge for many people. Dealing with a serious illness, and here we're talking about things like cancer, stroke. So these kind of problems can leave people feeling sad or anxious, but everyone experiences these life events, and usually after a period of adjustment, many will regain their emotional balance. Some unfortunately do not and may develop depression. So let's talk about that now. Next slide, please. The diagnostic criteria for depression is similar whether we are talking about young adults or elderly adults. So I've listed them here, and these are the things that the doctor, the clinician will look out for. The symptoms, as Dr. Chee mentioned, are things that should be persistent. So symptoms for 2 weeks or more. And the most two important ones that we would look out for, persistent sadness, sometimes associated with crying, a loss of interest. The other symptoms that are also present for a diagnosis of depression include negative feelings of hopelessness, guilt, worthlessness, or helplessness, irritability and restlessness, decreased energy, fatigue, difficulty concentrating, remembering, making decisions, a change in appetite. And again, as mentioned earlier, it can be a loss of appetite or an increase in appetite, and sleep can be affected. Both ways, a lack of sleep or increased time in bed asleep. Thoughts of death and suicide or suicidal attempts can occur as well. Okay, next slide, please. But what about symptom presentation in older adults? I think we do recognize that it may be different from young people. Firstly, it may be less obvious to everyone. It may be difficult to recognize some of these symptoms, and sadness often may not be the main symptom presentation, although that is something we need to look out for. Very often, somatic complaints, complaints of aches, pains, numbness, tingling sensation, for example, those are the common presenting complaints, and often also reports of fears of bodily illnesses. And sometimes when this is the presentation, we refer to it as a masked depression. Some may not also be willing to talk about their feelings, so that makes it difficult as well. Next slide. The elderly may appear to feel tired, have trouble sleeping, may seem grumpy and more irritable compared to their usual selves. There may be confusion or attentional problems that may make family members or friends suspect that this could be dementia, right? So the presentation is like a dementia or pseudo-dementia. Now, older adults also may have many more medical conditions such as heart disease, stroke, cancer, which can contribute to these depressive symptoms. And side effects of the medications also that they take may contribute to depression. Next slide, please. But what is interesting recently is a finding from a study. It's unpublished data, but it was a study which was done at the Clinical Research Center for Depression. And the study involved 135 older adults with a major depressive disorder. They were invited to report their symptoms on a scale known as the Hamilton Depression Rating Scale. And researchers then went along and analyzed the data using a statistical approach referred to as network analysis. And what they identified really were that the top 3 common or most frequently reported symptoms amongst those elderly with depression are firstly anxiety, secondly the depressed mood, thirdly insomnia, and in particular early morning awakening. So to make the diagnosis of a depression in an elderly person, a doctor will take a very detailed history, and it's best to try and report as many symptoms as possible rather than avoid talking about those symptoms that are present. The doctor will do a mental state examination. Sometimes the individual patient may be asked to complete a scale, a depression scale, for example, so that there is a record of the symptoms that they presented with, and also to establish the severity of the symptoms. Now, sometimes the doctor may also order some investigations to exclude other medical conditions that could be contributing to this mood state. So that's the doctor, and it's quite easy. It's very systematic in which they will approach the patient who presents with these symptoms. But what about close family members or friends? Can they pick up the signs and symptoms? Definitely yes. And it's possible if one is alert to the changes that are occurring in the elderly person. So keeping a lookout, noticing changes, and then trying and talking to that individual person about these changes and suggesting a review with a doctor is something that a close family member, a friend, a caregiver can do to help the older individual. Next slide. There are different types of depression, and I'll highlight a few here. The most frequent one is a major depressive disorder, and it involves all those symptoms that I mentioned earlier in the slide on diagnostic criteria. So the severe symptoms will interfere with the ability to work, sleep, in a younger adult study in Everyone Eat and Enjoy Life. And an episode can occur only once in a person's lifetime, but more often than not, there are some individuals who may have repeat episodes as well. So that's one, a major depressive disorder. The second kind of presentation is referred to as a persistent depressive disorder or dysthymia. Now here, the depressive mood disorder can last for at least 2 years or more. And usually they may not have all the symptoms that we talked about earlier, but some of the symptoms, maybe 2, 3, or 4 symptoms may be there in a mild fashion, but for a long period of time. Now, episodes of a major depressive disorder may occur along with periods of less severe symptoms. And when this happens, we refer to it as a double depression. Okay, so that means a major depressive disorder occurring when the person already has a dysthymia. Next slide. Another condition that we see, particularly with the elderly, is vascular depression. And here really the cause has to do with the changes that occur in blood vessels as we age. Now, as we know, older adults may suffer from restricted blood flow or ischemia. Together with this, there can be narrowing and stiffening of blood vessels, which prevent the blood from flowing normally, not only to various organs, but importantly to the brain. And when that happens, of course, the risk of a depression rises. So the risk of vascular depression is common with heart disease, with stroke, or other vascular illnesses. Next slide. Depression can co-occur with other illnesses. As I mentioned earlier, serious medical illnesses such as heart diseases, depression can occur. Diabetes, the rates of depression have been shown to be as high as 40%. Cancer, as well as Parkinson's disease. Depression sometimes can make these conditions worse and vice versa. So it's important to recognize and to seek treatment early. Sometimes the medications that are taken for the physical illnesses may cause side effects that contribute to depression. For example, corticosteroids are often used to treat inflammatory conditions. Prednisolone is commonly prescribed, and this unfortunately can affect serotonin, an important neurotransmitter in the brain. And so if long-term corticosteroids are needed or heavy doses are needed, sometimes these can affect the mood. Parkinson's medication for Parkinson's disease, they are important in regulating dopamine levels. Again, this is an important neurotransmitter for mood, for emotion regulation. And so there is also a risk of depression as a result of taking some of these Parkinson's disease medication. Next slide. So other causes and risk factors for depression, and there are several factors that may contribute to depression. I'm only going to highlight a few. There is a genetic risk. Again, we have not identified the actual genes that are involved, but we do know that those with a family history of depression may be more likely to develop it. Personal history, when depression has occurred at a younger age, young adulthood, for example, this increases the risk of late life depression. Biological changes in the brain, for example, as a stroke, as a result of a stroke or head injury and so on, where connectivity between different parts of the brain, where the neurotransmitters such as serotonin are affected, when there are changes in particularly the prefrontal cortex, the front part of the brain, again, these increase the risk of depression. And of course, stress, right? In the third slide, we talked about important life events and how they can contribute to depression as well. The next slide. So reviewing all the risk factors for depression in older adults, there are several things that we have to bear in mind. History of depression, a past history of depression in an individual, a family history of depression does increase the risk. Presence of chronic medical illnesses, again, is a risk factor. Gender, unfortunately, females are at higher risk than males. Being single, divorced, or widowed, and this in a way is related to the last item here on this slide, the loss of social support system that happens in this situation. So isolation and lack of social support for this group of people does increase their risk. Brain disease, alcohol use and use of certain medications, I highlighted two just now, and stressful life events. All these are risk factors that contribute to depression in older adults. Next slide. So what are the treatment options? And the important thing to remember is depression is treatable. We generally take a biopsychosocial approach. So starting with the biological approach, which is the use of medications. Now there are several antidepressants that are available, and we will look at that in the next slide. So when can we just go back to the previous slide, please? Okay, thank you. Sometimes when the depression is severe, right, and the person is unable to get out of bed, is neglecting eating, drinking, and the situation is really serious, then more important therapies such as electroconvulsive therapy may be needed to help the individual come out of that depressive phase. There are also now newer types of treatment that are available, and that is a repetitive transcranial magnetic stimulation, or TMS, that also can be tried for individual patients. So let's go back to antidepressants, and that's in the next slide, please. So the decision to start an antidepressant will usually be made by the clinician and in discussion with the patient. There are some patients who are reluctant to start antidepressants. They may want to use other forms of therapy, and that's an important thing to be discussed with the doctor. Today, there are many different types of antidepressants. The newer antidepressants that are available are much safer in terms of side effects. They have fewer side effects. There are much less risk of harm to different organs of the body in using them. But unfortunately, antidepressants don't act immediately. They take time, usually 2 to 4 weeks before we begin to see the effect. Now, certain symptoms may actually improve quicker before the mood lifts. So sleep may improve, appetite may improve, concentration may become better before the mood lifts. So that's something to bear in mind. Now, titration of medications is important because we are dealing with older adults. The doctors will always start low and go slow, which means that they will start with the lowest possible dose and gradually titrate the medication up depending on the symptoms and how the improvement is occurring. And how long to take the medication for? Again, it really depends on the symptoms, the severity, and whether there has been past episodes and how many past episodes there were. Generally, the first 12 weeks are important. So that is referred to as the acute phase of the treatment and the illness. And it's important that the individual, if they start the medication, take it continuously for that period of time. This medication does not act on an as needed basis. Once medication is started, it has to be continued regularly for neurotransmitter levels to build up in the brain. Then there is the next period of continuation of medication for at least another 6 months. Again, this has to be discussed with the doctor, whether the full 6 months is required or half that period is required. And it depends on case to case, it depends on the severity of the symptoms and so on. Now, for certain patients, those who have had recurrent episodes in the past, the doctors may actually suggest that maintenance treatment is used. So medication or antidepressants are continued for a longer period of time. Okay, next slide. So those are the medications that we talked about. So importantly, there are some people who do not need medications, but just psychological therapy will benefit them. And there are different types of psychological therapy. I've only listed a few here: supportive therapy, cognitive behavior therapy, brief integrated psychological therapy. The differences are in the approach and what is done in the therapy sessions. Basically, it involves one-to-one talking time with the psychologist who will help the individual in different ways. So it could be support that is only needed. Sometimes it may require more intensive work in identifying, for example, negative thoughts and teaching the individual how to deal with those thoughts, how to change them and move forward. Studies have also shown that when the therapy is targeted, for example, certain specific conditions, so therapy specifically for those who have had a stroke or those who have Parkinson's disease, then it is effective. And also therapy that is directed to special service settings. There are some individuals who live alone, right? And very different for some who live with family who are able to provide the support. And then there are some who live in nursing homes, for example, who may need a different sort of approach. So paying attention to these kind of situations, again, will provide effective response. Next slide. So the last one, and here we talk about the psychosocial interventions that are important. Now, psychosocial interventions have all at this point been evidence-based. Definitely physical exercise. So as the individual gains his or her strength, loses the tiredness, the fatigue, and is able to start exercise, that would be something that is strongly recommended to help improve the mood. Skills training, and here we're talking about skills in a variety of areas. Often it is learning to relax, learning to practice breathing exercises, getting involved in mindfulness practice, learning how to socialize, and of course, learning to identify the individual negative thoughts that are troubling them. So skills training is important. Group support, again, if that is available, it is beneficial. Reminiscence activities, as well as social activities. And there are a whole lot of social activities that are listed here on the slide. Under creative activities, they include choral singing, they include gardening, craft activities. All of these provide a sense of belonging and offers socialization. So in the early stages, in the acute phase, some of these things may not be possible. But as the treatment sets in, there's response to medication, then these can be introduced. Mentorship roles for older adults, again, has been shown to be very effective in helping them. And of course, family-style meal times, right? Sitting together with friends or with family members in a proper table setting, it does help in enhancing social interaction, independence, dignity. We do know from studies now that really a multi-component approach, that means more than one of these activities or interventions, is more effective than just focusing on one. And that is an important message. And I think the other important message that I learned today, and I think all of us should remember, is Dr. Wan's message about the 3 Fs: the faith, the fighting spirit, and the fearless sharing. So for those who still need help and unsure of what to do, approaching a GP, a doctor, that's possible. But there are also several helplines that they can turn to for help. So SAMH has a helpline, Silver Ribbon has a helpline, Caregiver Alliance Limited also provides helplines for caregivers, for family members, to friends to contact if they need more information as to what can be done. And with that, my last slide, I will end there. Thank you very much.
Thank you, Prof. Rathi. Your sharing has helped us to be better prepared to understand depression and identify early signs of depression. Especially in this talk, you are referring to the elderly. Yes, in fact, Prof. Rathi has done extensive research among the elderly. And for those friends out there, you still have questions, you can still type in the questions. Allow me to now introduce the final speaker for today. Professor Heok is a senior consultant psychiatrist at NUS and My Care Clinic and also Farrer Park Hospital. He's an international speaker who has spoken in many conferences, and he's also a prolific writer. Later, I believe he'll introduce to you an important book that you must read, Colors of Aging. And for now, I'd like to pass the time to him to share with us on the topic, Depression Prevention, First Singapore Study. Prof. Kwa, please.
Thank you, David. I'm delighted to be in this webinar. Although most of us have spoken in big international conferences, it's always wonderful to be back home and talk to the people here and see what we can do. Now, listening to Dr. William Wan, Dr. Chee, and Professor Mahendran, I'm sure all of you are feeling more hopeful now. There's hope. As you listen to Dr. Wan, by the way, about last week, he wrote a column in the Straits Times on Am I My Neighbor's Keeper? It has tremendous impact because there were many people wrote in a forums section on newspaper the following few days. And even my friends asked me, hey, have you read this column by Dr. Wan? It's so impactful. I've written about 25 books, and I don't think they're as impactful as his one column, the Straits Times. Dr. Chee also mentioned about prevention. I think that's the way you should be going. Instead of all we are doing in our clinics in NUH, in my private clinic in Farrer Park and the university, it's just downstream work. People who have depression come to see us. As you listen to Professor Mahendran, we think of what medication to go, what kind of psychotherapy to introduce. It's all downstream. And I mentioned this to the president of NUS last week and said, in fact, yesterday, that we should be doing upstream. Can we prevent this? And this is the challenge, not only in Singapore, but the world. Next year, sometime in March, there's a World Congress of Psychiatry. They've asked me to chair a session, and it's on something positive mental health. Is there any success in what we're doing? And this study will be quoted. And once again, Dr. Mahendran also mentioned about preventive measures. I'm very glad that in our study, we are supported by the Guan Yin Hu Cho Temple. Dr. Tan Jong Kim should be listening in, and it's the first study in Singapore on depression prevention. Next slide, please. This is the agenda. I'll talk to you about the heartwarming news. I'll tell you about the challenges we encounter of aging. And if you cannot remember many things I'm going to tell you today, just remember just one fact. The fact is depression is preventable. Next slide, please. The heartwarming news, can you show me the slide? Is that firstly, the public wants to know more about mental health, which is very good. I think there's so much in newspaper now. The government is talking about mental health of foreign workers, and I'm sure they are also interested about the mental health of the local Singaporeans. Policymakers are keen to do more, and this morning's news about $2 billion will be spent on research, and I hope they will give us a slice of it for mental health research, and the VWOs and NGOs, including PCS, are all involved. And the second important fact you must remember from this webinar is there's a program called Age Well Every Day in 8 community centers here in Singapore. And this program is structured program. I'll tell you more about it. It's also evidence-based on research done mainly by Professor Mahendran. And thirdly, we measure outcome. So we are introducing the program which has an outcome, very important for us to find out what happened. So this study, which I'm going to talk about, is at Jurong. Next slide, please. So it's the 10-year follow-up study at Jurong Point, and it's here that the Lee Kim Ta family gave us a space. What we did also to, there are 50 blocks of flat around Jurong Point, and we send our nurses to knock on the door of every apartment around Jurong Point, and anyone above 60 years old will be invited to Jurong Point for a very thorough assessment, very thorough indeed, physical health, mental health, social health. And those people who have some mild symptoms of depression, but not major depression, as you heard from Professor Mahendran, we call it subclinical depression or subsyndromal depression. They have some sleep problem, they have some energy issue, they have a low mood, and these are people who do not have the full-blown picture. They don't need to be treated with medication. We think a non-drug approach would be better. But we know that we first talk to them about, we give them health talks. We tell them what is depression, but we don't tell them depression is linked to other things like diabetes, hypertension, even the food we take. If you like vitamin B6 or B12, we also are more prone to depression. And after that, we divide into 4 groups. One group for Tai Chi exercise, another group for mindfulness practice, another group for music, the third group for art. And Professor Mahendran mentioned something very important, and it's the results of this study show that it is no good just to do one thing, Tai Chi or mindfulness. It's good to have more than one. All right. So this is a trust of the message we give to people in Singapore, because invariably, when I do a lecture on dementia, someone will talk to me about, hey, you all did playing mahjong is good for the brain. Can I just do mahjong myself? And no, lots of things you must do besides mahjong. Another will talk about, hey, what about coconut oil? So it's the combination. So normally after I finish all the methodology, then I'll tell you the results. But I thought today I will do it differently. We'll tell you the results first. Next slide, please. The results tell you that the good news, the very good news is that in 2011, when it was first launched, it was in fact launched by our Deputy Prime Minister, Mr. Tharman, in 2011. At that time, we did a survey of these old people in Jurong. It was about 7%. 7% seems small, but multiply 7% by all old people above 60 or 65, it's about 35,000. 35,000 people with depression, depression. This is depression. But now, if after the intervention, we find that in the Jurong study, it has dropped from 7 to 4. So in fact, it's wonderful. You're able to save 3%. And 3% of the population is about 15,000 people. 15,000 people with the intervention we've done, music, art, mindfulness, exercise, all this can bring down depression. But exactly what do we do? I'll tell you next slide, please. So you see the blue column on the extreme left is the music, followed by Tai Chi, followed by mindfulness, followed by art. So within 4 weeks, those in the music group improve. And then later on, by the 10th week, there's also mindfulness and art. And after a year, all improve. Now, so all these activities can lower down the depression and also anxiety. Someone asked me, is this because of your Tai Chi or your music, or because they come together? Well, that's a difficult question, which I'll talk about later on. But we also want to find out in a more detailed way. People say, well, what about this mindfulness thing? How does it do it? So next slide, please. The next slide will show you that the change of mindfulness, we scan the brain before the study. So the top is the brain in pink will be the area in which we have health education, the control, and the blue are those with mindfulness. I'm not too sure whether you can see my pointer here, and the B plane shows you what happened after three months. That all you see that even health education, they increase in number of brain cells. That the cell can communicate more. But people with mindfulness seem to do much more than that. So this is also the first study in the world using MRI brain scan to assess the changes in the brain after mindfulness practice. Next one, please. We also did a study on art and music, and this we conducted over at the National Art Gallery. I'm very thankful to the gallery for giving us this opportunity. And many of these people who come down here, you realize that if after 10 weeks, again, or 3 months, again, there's an improvement of their mood and also their social health. And we selected the kind of paintings that they are more familiar with. So the upper painting is Upper Nama Awa, sometime in the 60s. So they know that time Malay language was introduced here in Singapore. And the second one's a scene in Chinatown. So these are things that remember this art and music reminiscence. The third one is on choir singing. Next one, please. And we found that choir singing, you see there is a Dr. Maureen Sarkok here, and she was very enthusiastic in doing this study. And after about 1 year, we found that not only do they become better in terms of their mood, many of them became to know each other better now. Before the study, they be living in the same block. They don't know that Mr. Tan is living at level 3 or level 4, but now they became to care for each other, which is very important. And there's an incidental finding that, as you mentioned earlier on about depression, that many people live alone and then go into depression. And so this kind of study, people begin to care about the neighbors more. So Dr. William Wan mentioned about, am I my neighbor's keeper? Many of these people begin to care for their neighbors, help them out, especially during the pandemic. The next slide, please. The next one, we move on to gardening. This is the brainchild of the chairman of National Parks, and we brought elderly people from Jurong Point to Gardens by the Bay. We introduced gardening for them, and we measured the change. The one wonderful thing about the change is that we took some blood from the elderly before and then after 6 months. And this is what we found. Next slide, please. That there's, besides the feeling better, there's also improvement of their immune system. There's a lowering of a kind of inflammatory proteins called interleukin-6. Now they become more resilient to infection, to common cold and all that. And this is marvelous because we find that people become more resilient, not only mentally, but also physically. Next slide, please. And after the study in Jurong Point, we were asked, why not we extend to more centers around Singapore? And this is called translational research. And I'm very glad that the Kuomintang group on the extreme left north, and then Bishan North, Hougang and Tampines, Eunos, Queenstown, and I'm not too sure another area, Changkat, and also Changkat is down there. One more called Hougang also involved. So it's about 8 centers altogether. Now, what are the challenges? The challenges is that we only have 8 centers. I hope that all of you who are listening in, who don't have the all program in your constituency, you will talk to your member of parliament and measure them and say, hey, we must have this program in our center, because it's very important, because we realize that if you prevent depression, you can bring down suicide. Now, every day in Singapore, someone is contemplating taking his life. There are more than 400 suicides per year in Singapore, which means that every day there's somebody. A suicide is preventable. And often before they take their life, there's a period of depression. If you can pick up the depression, it'd be wonderful. You can be able to treat them, the patient will be well. And as I said, we know that today, announcement on newspaper, on television, $2 billion spent on research. We think we should get a slice of it and something for the community. And all this program we are doing is to build up a very resilient society, not only for the youth, but also for the elderly. So it's a continuum. This is the main aim of the NUS Mind Science Center. We want people to have an undefeated mind. The next slide, please. Right. An undefeated mind, that we can go through life and not be afraid. And you listen to Dr. William Wan. He's a role model. He went to difficult times, and your family itself with chaos, your work, you're in chaos, but he survived. So this is the most expensive painting in Singapore, and I own it. It's in my house. I'll tell you why, because I was asked to do a painting by the art therapist in England, And this is what I painted in. And she asked me, what does the house stand for? Well, I told her that the house is a home, a family, very important in your life. The oak tree signifies values in your life, values of filial piety, values of integrity, value of care, compassion. And then you see a lot of waves in the front, the lower part of the painting. Those are the stressors in our life, that we have to overcome. It's a long and winding road. I think Dr. Wan mentioned the long journey. And at the top of the painting are the gray, the future crises we encounter. But if you have a strong family, you have strong values, and you have good social support among your friends, that'll be wonderful. Yeah. But people tell me, hey, what you said yesterday, 2 days ago, or I think yesterday, I had a lunch with some professors. They said, what you have done, we also know, many years we know that being exercise is important. We know that art helps. What is so wonderful about this Age Well Everyday program that people are talking about, that is published in big journals around the world, and we are giving lectures as far as Harvard and all these places. So I tell them that, well, I was reminded by this picture of next slide, please, of the 3 Chinese deities that represent Fu, Lu, So, health, so wealth, longevity, and happiness. So they told me that, look here, the ancient Chinese knew about all this long time ago, that you grow old, you must also have money, wealth, that be happy, and you will have a lot of happiness in your life. And I think they are right. I think these people who are a bit critical are right, that it's true. A lot of things they knew about it in the past, but what the Mind Science Center does is to show you the science of it. Why is that after you mindfulness practice, you feel better? In fact, yesterday we have a paper also done by the principal investigator is Professor Mahendran, that if you do mindfulness, it changes the bacteria in our intestine. The bacterial intestine affects the mood, make you less depressed. So these are the signs which the ancient Chinese didn't know about, but we will tell you what it is, we'll explain it to you, so people will believe us. Everybody in Singapore ask me, where's the evidence? This is the evidence, it's coming out. Not only is the MRI brain scanning, but also the gut bacteria. But I tell you, the ancient Chinese didn't get it all right. You look at 3 of them, they're all men. But that's wrong, because most of the people who grow old are the women, it's not the men. And you see all the 3 of them are quite heavy and fat. Obesity is a risk factor, for hypertension, diabetes, and so although we say the ancient Chinese is correct about the 3 deities, they're also wrong in some ways. So I want to thank all of you. Everything that I mentioned to you are already published in a book, as David mentioned. Next slide, please. It's called The Colors of Aging. I want to tell people that aging is not all gray. Everything is down, and people say aging is the 5D: dementia, despondency, decrepit, depression. The people are down. But no, there are lots of people who are very active, who are very who are part of the community and contributing to the community. And I said the poster boy of active aging is Dr. William Wan. He's older than I am. He goes rock climbing. You want to scale Mount Everest. He went across every part of the world. He survived. So I think we want to close this, but I'll tell you that all the program in all is not stagnant. It's moving all the time. It's organic. There are other programs in Singapore who are also mimicking elsewhere, and they have the same programs day in and day out and month. But in Mind Science Center, we introduce new programs which are evidence-based. So, for example, like the therapeutic garden is done by research. Now we are moving on to the therapeutic forests, which we just finished. We're going to have a training program, and those in our program can go to the forest, walk through mindfully, and learn something about the forest. And Dr. Chee is doing a study on Chinese painting. Chinese painting also requires a lot of concentration. Mindfulness practice is very important. And yesterday, 2 nursing professors told me they are keen to do something on dancing line dancing. I told them that, okay, if you want to do this program, show us the methodology before we can find out how we can fund this program. And if it's true, it's helpful, then we introduce to all the centers on line dancing. So as I listen to all of you and on our research, I think there is hope in many things that we do. We tell people that dementia and depression are preventable. Initially, people are all skeptical. In fact, Professor Mahendran will remember there were 2 doctors who wrote the newspaper that dementia is not linked to exercise or food. Yes, they are. Though that was about 10 years ago. So you see, we knew all this thing. People want the evidence, and if you have, when I was a student, the lecturer told us, that was in England, that where there is no hope, the doctor must prescribe hope. You must think about it again. This is a line from a French novelist called Albert Camus. He said that where there is no hope, the doctor must prescribe hope. So people with cancer, when they are trying to cling on to life and when there's no hope, we must give them some hope. And if you come to NUH, in the foyer, there's a sculpture called Hope. And below the sculpture is inscribed the words of Alexander Pope, and it says, "Hope springs eternal from the human breast." I'm hoping that in future, we don't have to quote from Alexander Pope or Shakespeare or Wordsworth. We'll quote from other people who have done so much work, people like William Wan. We'll quote William Wan in future, maybe in future sculptures in NUH, all the wisdom you have. So thank you very much.
Thank you, Prof. Kwa. I liked your painting, The Undefeated Mind. And in the painting, there is this house signifying home, signifying importance of family. And I believe with a strong family, it's easier for those who are going through difficult times to find the needed support. And this is expressed by Dr. William Wan and even Prof. Rathi and Dr. Chee, whereby we learn to look out for children and even elderly who may have signs of depression. And I think what is wonderful about this talk that I can take away is that there is this good news, there's this heartwarming news, and there's hope to keep away depression. And so we have a number of questions being put up by our participants. Let me take a look at the questions. And okay, there's this question. Yeah, Dr. William Wan may want to answer this, and perhaps other speakers too can contribute. Is depression a mental or spiritual issue, or a combination of both?
Thank you, David. I like to think that we are both physical, spiritual, emotional, psychological. We are whole, a holistic being. And I think that when you believe that the human has a spirit, then that spirit is in contact with a higher spirit, then that is spiritual, however way you define it. So I think it's both, because whatever affects us in one way will also affect us in another way. And that's why for me, choosing to believe in the spiritual, to have some spiritual practice. I forgot to mention that when I say that I pray, I also mean that I meditate. And meditate is a form of contemplation, a form of mindfulness, where you center down and you connect with the spirit that is much bigger than you, and you seek help from a source that is much bigger than you. And so, yes, I think it's a combination.
How about the other speakers? Do you want to respond? If not, I have 2 questions here. I'll try to put it into one. Has to do with children, and so probably Dr. Chee can help to answer this question, where a daughter has school anxiety and depression, withdrawn from school, has been on medication for 6 months but not effective. What can parents do? And what can parents do to help their children who refuse to see a doctor? So, Dr. Chee, please.
Hello, hi. Sorry, without fully understanding the various contexts, hard for me to answer in specifics, but I will give general advice. There usually are reasons why children are reluctant to see a doctor, to see a psychiatrist, and often we try to think of it as what are the secondary communication that your child is trying to share with you, or somebody else's child is trying to share with their parents. Sometimes talking about it, trying to understand it, and sometimes even if it means that as parents we have to be a bit more firm to say that, you know, I really think this is important for you, we should see the doctor. Tell us why you don't want to see the doctor. Is it because of what the doctor had said to you, and all that kind of stuff. You might not get anywhere initially, and that's why it's very important not to wait until like 10 minutes before going out of the house for the appointment to start having all this kind of discussion. Sometimes what is important is to try and communicate beforehand. After the first session, what has happened? What has the medication done? So just to add one more thing, something that I often share with all the young parents that comes to our clinic is they often say that they don't understand their children, and the children often say that they don't like to share with their parents. And what it is there is a lack of two-way communication. And then when you ask the parents, and I'm not saying this is what you are going through, but when you ask the parents what they're going through, there is this sense of such busy lifestyle in the Singaporean modern family. At 7 o'clock, they go to school. After school, they go for after school classes. And by the time they come home, it's 6 or 7 o'clock. They have dinner, they wash up, and then time to do a bit of homework and then go to sleep. So there was no way to talk. So one useful tip that most families has found really helpful is we prescribe, or we say, take 5 minutes every day just to talk about how you feel today. And the parents can role model by saying, today I went to work, I felt frustrated, I felt great, I felt I did something meaningful. How about you? And from there, you build small pieces by pieces. And then with better communication, a lot can be done. I hope that's helpful.
David, Dr. Chee is a very good child psychiatrist, and he interviewed many people. And he mentioned that many of his patients told him that school is very stressful. And I hear this all the time also because I look after the university students. And I'm quite amazed because when I listen to Dr. William Wan's Sunday morning chat, he enjoyed his time. I thought he was from one of the elite school, you know, like RI or Hua Chong. He told me he come neighborhood school. And he enjoyed going to school, you know, just like Professor Mahendran, she enjoyed going to school. Even Dr. Chee, actually from Indonesia, isn't it? He came over here to Singapore, he enjoyed school. You know. Now, what has gone wrong with school? I really don't know. Whether maybe there's a starting point now. I hear that the Ministry of Education is starting what I call mental health literacy, which I think is very good. And last year I was invited to give a lecture in Japan, and they asked me, also there are a lot of problems in Japan in schools. You know. So I told them there's something on mental health literacy to be taught in schools, you know, on how to promote mental health, how to build up mental resilience. And there were a couple of people from MOE, and they said, well, we're trying, we'll go back and we'll tell the ministry that these are things that can be done. So I think it's possible to make some changes. So people say, well, it can never change. No, things are changing, and I'm glad. So there's hope that in schools that maybe, you know, Maybe William, tell us why is that you enjoy so much of school, William?
Well, I suppose we were products of our time. I mean, in those days, the differentials between schools were not so great. I mean, I came from Bartley. We played soccer and rugby and a lot of sports, gymnastics, and we were allowed to grow up as teenagers, having a lot of energy to be spent on the track and on the fields and so on. We played with elite schools, and we didn't even think that they were elite. So the emphasis then was different, and so we enjoy just having fun. When we have to study, we studied, but we also played, and we played hard. And I think that was the best time to grow up in. I'm not sure about growing up today, though. I mean, if I were to, can get back in the time, the time thing, and become a teenager today, I'm not sure I will be enjoying as much as I did when I was a teenager.
I agree with you. I think as I listen to William's Sunday morning chat, you see that in his time, there was no tuition, He didn't go for tuition for this, tuition for that. He just play rugby every day, and his friends, and he goes singing and all that kind of thing. And same as where I come from in Malaysia, in Batu Pahat. There's no one goes for tuition. I never thought about it, that you need to have tuition. And I tell the people, that the principal of all the elite schools, that the teachers are so well trained. Why must we send our children or grandchildren for tuition? Why not give them time to play games, enjoy music, and then there's so much to learn outside of schools. Whether maybe what do you think, Dr. Chee? You are closer to the youngsters than all of us.
Yeah, I fully agree. I think it's really difficult in our current society. There are so much demands, not just the traditional academia, the extracurricular activities, but also there's this social demand. Now, young people more than ever before have to look a certain way, talk a certain way, be social in a certain way. They have to have additional presence in their social media profile. They attracts all kind of attention. Some attention are positive, but some are negative. And it's just a lot of stress and demands on their time. It's not so straightforward anymore. And I think that is probably why it's not a coincidence. There is an upsurge in anxiety and depression, mood disorder type problems in these times than ever before.
Well, I quite agree. I think, David, I think the dialogue on the mental health issues, so not just between William and myself and Dr. Chee, Mahendran and you, it should also be discussed by people who pace the corridors of power. They must be involved in it, and rather than ask us to go and do all this, what about this? What can we do? What can Dr. Chee do? His clinic, we ask him to run 10 clinics a week. What can he do? He keep on doing downstream work. What is upstream? What are things that's trouble the school children? These are issues that we need to face and counter. And even the post-pandemic era, more of these issues coming up again.
And my children will agree if there can be more play than studies and exam. I think their life will be happier. Mm-hmm. Yes. And we have another set of questions that has to do with medication. Yes, somebody mentioned that someone took paroxetine, I don't know whether I pronounced it correctly, for 5 years and wanted to come off medication. So the question is medication for depression a lifelong treatment? Can they stop? Okay, and then will there be long-term effect? Maybe Professor Rathi would like to answer this question.
Yes, yep, I can take that question. So I did mention that long-term medication really, when a doctor decides or recommends that, you can hear me, right? So long-term medication, or when the doctor recommends what we refer to as maintenance antidepressant medication, there are usually very specific reasons for that, and that includes many recurrent episodes of depression in the past, severe episodes, maybe suicidal attempts, and so on. So going off medication when someone has been on long-term medication really requires a close discussion and review by the doctor to decide whether it's safe to go off medication. Now, long-term medications have few side effects, especially the newer ones. You can take them long-term, but some do cause problems like maybe weight gain, which can be a problem, and things like that. So it's not that they can cause serious problems, but there may be some side effects that can occur with long-term medication use. Now, the third thing is, rather than stopping medicine abruptly, if someone decides or the doctor decides medication can be terminated after a period of time, is always to go slow and gradually titrate the dose. Remember, I talked about gradually increasing doses, titrating doses up. So at the point where a decision is made that yes, can go off medication, then medication must be gradually titrated down, and the titration period can take weeks, months before the individual is weaned off the medication. I hope that answers the question.
Can I add something, David?
Sure.
The treatment of depression is no longer just giving a drug or just psychotherapy. Also, it's often a combination. So although if we see patients, we try, besides giving medicine, we also do psychological therapy, which is a better word. But also I tell them there are many things you have to do. You have to restructure your life, also exercise. There's also music. There's some patients, I tell them, there's one patient who's a school teacher and a music teacher. They try music therapy, music, art in the form, even mindfulness. Mindfulness doesn't cure your depression, but it's part of the whole package that we give to people. So as you wean off your paroxetine, then you carry on the psychological or the talking therapy, but also allow them to try various things. Exercise itself, all this, many often they'll tell you that they lost the confidence, the self-esteem gone down, but now they're able to perform, right? Even doing choral singing, that itself helps in the mood itself.
Yes, in fact, I find it very helpful that apart from medication, there can be other forms of therapy, such as music reminiscence. And I think there's this program that is going on that has rolled out in a few constituencies, the Age Well Everyday program.
Mm-hmm.
Yes, maybe Prof would like to tell us more and how can the participants be involved in this Age Well program?
So as I mentioned in my lecture, it's available in 8 centers, but we think it should be throughout the whole island because other people in Indonesia are keen, Malaysia are keen, and even China, they're keen. I think within our own country itself, people should and it's a non-drug approach. And it's free, by the way. But sometimes Singaporeans say free, not very good. We should make a charge. I think listening in are people like Gopal, Pang, these people are running this program, and they have been very well trained in NUS. So if you have it, if you're staying in Punggol or in Pasir Ris, you don't have a program yet, then you go and badger your member of parliament. Hey, we must have this program, because they have it in Queenstown, and they have it in Jurong, and the prevalence of depression has dropped down. We must have it. So I think it's good to pester your member of parliament and say we should have this program.
There's another interesting question. Okay, any of the speakers, feel free to answer. For elderly person who has very advanced dementia and has lost the ability to speak, how can the family or caregiver tell if the elderly has depression?
I thought I'll let Rathi go first, and I'll think about it.
Okay, so maybe I can start. This is a very difficult question to answer because a lot is unknown, but maybe I'll try my best to sort of explain the situation. Now, I'll start by looking at when depression occurs in the elderly person. One of the things that the psychiatrist will be looking out for is also whether there's cognitive decline. Very often, depression does herald cognitive decline in the elderly, right? So that is in the very early stage. They will not do the assessments for cognitive functioning at that point, but they will treat the depression first before assessing the cognition. Now, for patients who have early dementia, depression, anxiety, psychotic symptoms can occur. These are neuropsychiatric symptoms that present with dementia. And we refer to them as BPSD, or behavioral and psychological symptoms of dementia. But as dementia continues and increases in severity, it really becomes a challenge then to try and identify whether there are still depressive symptoms. Now, I was looking at this chat, and I think some of the issues were there was that it was not possible to communicate with the individual. There was significant apathy, isolation, and withdrawal. And so it becomes very difficult to engage and try and elicit symptoms in this individual who presents this way when there is severe dementia. One of the things that one can look out for, of course, is if there are episodes of crying, which can indicate the presence of a depression. But beyond that, it's really observing the person closely and getting a clinician to assess the individual. I think that can be the only way in which definitive diagnosis of depressive symptoms rather than major depression occurring in severe dementia, right? So if you're looking at depression in severe dementia, it is as part of BPSD. Sometimes also it is very difficult to experience those depressive symptoms at that late stage because there's already so much damage to the brain. So probably what you're seeing in terms of the lack of volition, the apathy, the indifference, the inability to communicate are really part of a dementia picture rather than depression. So Prof, maybe I can invite you.
Thank you. I think you've answered most of the points, Rathi. I think it is a very common issue, diagnostic dilemma, when the patient with dementia has also depression. So we have a lot of referrals that come only from Singapore, but Indonesia, Malaysia. I have a patient that came as far as Tokyo, Shanghai, and in Australia for a second opinion, because the NUH center here was the World Health Center for dementia. But so they are often in a dilemma: is this depression, this is dementia? I once asked to look after one of the professors here, one of the surgeons, and they thought it was just a pure depression because he became slow, he became a bit forgetful. So they said, well, it is just a depression, you know. But later on, I told the family that besides the depression, he has also an underlying dementia. So, so I think it's very important to recognize that these two are coming close together, comorbid. And you think about it, is in a way is quite understandable. If someone who is very active and then suddenly you realize that your memory is going down, you tend to become more, you see, a reactive kind of depression comes in, depressive symptoms rather than a major depression. So it's very common to see this kind of problem very early. So if you are listening, I hope you will tell your family members to stick on to one particular doctor. It's easier. The doctor can see the changes in the patient. You jump from one doctor to another, it's very difficult. But also, if someone cannot speak, I often write down, if you can read, I'll write down and show them the picture. Sometimes after a stroke, you cannot speak, you know, to show them, write down and see, how do you feel? How's your sleep? You know, talk about sleep, ask the family the appetite, about energy, are they most energetic? And also their mood, as Dr. Mahendran mentioned, you become very tearful, you know. And you see that some of these signs of depression, if you treat the depression, you know, and if that particular time comes, you need a medication. Once the mood improves, it also lifts up in terms of the cognition, the memory function, and improve the quality of life. And it's wonderful. They are more eager to do other things, especially for people with old people, with elderly people with stroke, with some memory problem, and also depression. After you treat the depression, then the mood improves, then they're more eager to do your rehabilitation. Because sometimes I'm asked to look after, to help an old family where they say that my father refused to do all the rehab exercise and actually having underlying depression. It's no use trying to force him. He will not do it. So if you can see one particular doctor, you can follow a long period of time, he sees the changes and he'll say, okay, maybe we give an antidepressant and watch how he responds. Once he responds, you find that, in fact, his memory also improved a little bit. He's more attentive now and he's more eager to do some exercise for you. Even your art therapy or your music, you tend to participate more.
Thank you, Prof. Time is catching up, and I think there's one very important question, and so I'll leave this question as the last question. How to help those with suicidal thoughts and who refuse to seek professional help?
Look at this. Look at this. Whoa, look. I'll show you that.
I think this is a very important question because it involves life and death. How can we help those with suicidal thoughts and they refuse to seek professional help? Okay.
Maybe I can start by saying a few things from our research and also from my experience with working with young people with a lot of suicidal ideation. This is a very interesting year in the sense that the number of young people who presented to NUH with suicidal ideation has probably doubled. Haven't counted the numbers exactly, but probably doubled. And a lot of them came seeking for help. A lot of them came because the parents or somebody who is close to them brought them in by force. Sometimes they bundled them into the taxi, in the family car. Sometimes they call the police. Sometimes comes through the ambulance. And to answer a very difficult question, how do we help them? I think the first straightforward answer is get them help professionally. So if it is a suicidal ideation, suicidal thought, then seek help with any hospital that has psychiatric facilities. I think that is really important, really number one. There will be a small number who doesn't want help, and often these are the cases where they are very, very clouded by their depressed feelings. They're very, very clouded by a sense of hopelessness. They felt hopeless, hence they want to die. They felt hopeless. That's why they didn't think it was worthwhile going to seek help, because help will not be forthcoming. And I will argue that these are the cases that if you do know or you suspect, then please either convince them or by hook or by crook, be it if that means calling the ambulance or the police, get them the help they need. So that is number one. I will leave the more nuanced, subtle kind of answers to the other more distinguished speakers in the panel.
Maybe ask Prof. Rathi.
I actually think Dr. Chee has actually stated some very important things. I mean, if they're refusing and they're really concerned about the risk, then sorry, I haven't put my video on. I realize, yeah. So if the individual is expressing these suicidal thoughts and family is concerned, then the only way is to do their best to get them to a clinician, psychiatrist, someone who can assess the situation and make appropriate recommendations. I think that's the most important thing. That's the most important message we can get across today. Thanks, Prof.
I think the issue is in terms of risk management. So if someone is depressed and suicidal, it is almost mandatory that they have to be seen by a professional person. For example, a psychologist in NUH, they would like to refer to the psychiatrist, because if there's a death, there will be a coroner's case. The court will call up and they'll ask the psychologist or the counselor, have you referred to a psychiatrist for an assessment? So it's always good to so-called pass the buck to somebody else. So you got to, for all of us, we have to do a risk management. Shall I intervene? If it's really, the person is really going to take his life, then as Dr. Chee mentioned, you better call in the police, to send the patient to a place of safety, either to a general hospital or to IMH. But sometimes you listen to it and then tell yourself, you refuse admission, maybe I'll just go through the family doctor, who know the patient well. That's why I always emphasize, if you can have the same doctor, it's much easier. I always tell this about Professor Goligan, who's our professor of family medicine, and he referred me a problem 2 years ago on Chinese New Year Eve, and that's before my Chinese New Year dinner, family reunion dinner. He rang me and said, there's a doctor who is depressed and suicidal, what can I do? And he said, I tried with him for the whole day. He says, no, he's going to take his life. And so he said, can you help me out? So I listened to him. After I listened to him, before I make any comment, he told me, Heok, I'm so happy I talked to you. I said, why? Because I've unloaded my problem to you. And he said very frankly to me, if this person takes his life tonight, two of us will be sent we have to face the coroner, the judge. And I'm sure you will face a heavier burden than me because you're a psychiatrist. And we have to take that kind of risk ourselves, And but the fact that he able to unload it to tell someone, he reduced his mental load, his anxiety, his fear. And fortunately, we were able to make some adjustment, and the person didn't want to come. And I told him, okay, if you don't want to come, maybe I'll see the person tomorrow or the day after until the crisis is over. And this is something that we often do, but at a high risk to our own professionalism, that you tell yourself, if you take the risk, you tell yourself, I don't want to, the patient refuse and the police says we cannot do anything, or the patient stay in the room and refuse to come out, we sometimes take high risk, and they may be a mistake. So far things are okay. We have to see them quickly. If the patient is really suicidal, we often assess them with a assessment instrument, inventory, and find this is high risk, then the police will come in and often take them away and for a place of safety and make sure things are okay. I hope I answered that question. I know it's a very difficult question that we often struggle with, and the things that I hope it doesn't come to that level. That's why we're thinking that if you can detect depression early, detect this early sign early, then we can nip the problem in the bud. And also in school, you can do something in school. That's why I was thinking that even in school, if they have counselors in school who intervene early, then we find that it's wonderful.
Thank you everyone, especially the participants. Unfortunately, due to time constraint, we are not able to answer all the questions. I'd like to thank all of you for participating in this webinar, and I think we do have the finest of the finest speakers among us, and we have come to know that their professions has heavy responsibility as well, whether as a psychiatrist or as an ordained minister or lawyer. Thank you very much. I'll pass the time back to Kanika, the MC.
Hi, welcome back everyone. It has been an interesting Q&A session. We have come to the end of the webinar. Thank you everyone for tuning in. Thank you Dr. Wan, Dr. Chee, Professor Rathi, Professor Kwa, Mr. David Lim for your insightful sharing. We would like Also to express our appreciation to Mr. Lee Sun-tik, NUS Mind Center, all the team members who had made this webinar possible. Have a good evening.
And thank David and all his team at Kaniga.
Thank you. Goodbye, everyone.
Bye-bye.